Kia ora koutou, nau mai haere mai ki tēnei kōrero. My name is Ben Birks-Ang. I'm the Deputy Director in charge of programs at the New Zealand Drug Foundation. And here we're going to see another highlight from our recent symposium. This one we're going to hear from Professor Nicole Lee talking about methamphetamine. Some of the stuff we know about methamphetamine in New Zealand, people tend to wait 5 to 10 years before seeking support. So as we look to address the methamphetamine situation in New Zealand, we need to look at what works for people who are currently experiencing extreme harms, but also zoom out a little bit to see what can work earlier to prevent people from having those harms escalate. So Professor Nicole Lee is the founder and CEO of 3 adjunct professor at the National Drug Research Institute and an expert advisor to the Australian Government on drugs. This is Nicole Lee.
So super excited to be here. I was at the very first one of these, and for Sarah, for your information, with Alison, which was 2017. But I am especially excited to be allowed outside of Australia for the first time in more than a year. So thanks to the NZ Drug Foundation for the invitation, and also thanks to my favourite world leader, that's Jacinda, not ours, for opening the bubble so I could be here in real life. Now, in Australia, we would normally, I would normally do an acknowledgement of country of the Aboriginal people, the owners, the traditional owners of the lands that we would be speaking on, but I know that you don't do that here, but I think it is worth, just before I start, acknowledging and reflecting on the disproportionate impact that alcohol and other drugs has on First Nations people in Australia and in New Zealand. And so everything that I'm talking about is kind of amplified when we're talking about disadvantaged groups, First Nations people, people with mental health problems. All right, so most of the community is under the impression that drugs are illegal because they're dangerous, but it's actually the other way around. A drug's legal status isn't necessarily related to its relative danger. It's much more to do with kind of quirks of history, as we've heard from Alison just a minute ago. And in fact, drugs like methamphetamine particularly are much more dangerous because they're unregulated. They're manufactured by backyard chemists in clandestine labs. Meth is a really good example of this. This is an ad for methamphetamine to treat obesity from JAMA. That's the very prestigious medical journal in the US from 1954. You might be able to see, I'm not sure if you can see at the bottom, it was available in lots of different formulations and lots of different sizes. And it was a pretty big thing. So you can see this is methamphetamine hydrochloride. This is a benzodrine inhaler, so it's a form of amphetamine, which is a slightly different formulation to methamphetamine, but it's a similar kind of drug. And these were available over the counter. You didn't even need a prescription for them through the 30s, 40s and 50s. This is a photo from, I think it's about 1948. Millions of them were sold, especially in the US, for everything. If you had a problem, this could fix it. There was even a song written about it, which you can Google. It's on YouTube, and it's called "Who Put the Benzodrine in Mrs. Murphy's Ovaltine." It was released in 1946. So this is a service menu from the old airline Pan Am. If you're as old as me, you might remember that airline, and it died somewhere along the way. This is from 1948. You can see where I've just highlighted there, you can get the benzodrine inhalers on the service trolley. It was marketed as a bit of a pick-me-up for a long flight and a jet lag cure if you were on a long haul flight. What I love especially is that you can see on the right-hand side the alcohol you had to pay for, but the amphetamine was free. If we just fast forward to more contemporary ads, these are ads from Australia that reflect quite a different view about exactly the same drug, really. In Australia, we call the crystal version of methamphetamine ice, and that's why it's called Ice Destroys Lives. What are you doing on ice? I think these are all government ads. I think they're over-sensationalised and a little bit ridiculous, to be honest, but they do reflect the significant concern about these drugs in the Australian community. What these two kind of juxtapositions show us is that when amphetamine and methamphetamine were regulated pharmaceutical drugs, there were relatively few problems. There were certainly people who were dependent, there were certainly people who had some issues with it, but not to the same extent that we're seeing now. Once they became illegal, the problems amplified, and you can see as we get stricter and stricter with drugs, the problems get worse and worse. So we need to do something completely different. But let me also just put this into perspective. In Australia, the best estimates are that about 1.3% of the Australian population has used methamphetamine in some form at least once in the last 12 months. The figures are pretty similar for New Zealand. It's about just over 1%. Now, both of these figures are probably slight underestimates because of the way the data is collected, and I can talk to you about that some other time. But even if we said the rates would double this, which they certainly wouldn't be, in reality it's what we would refer to as a low prevalence use of a drug, compared to cannabis, for example, which a large proportion of the population has used. In fact, in Australia, you can see here, the dark blue line, that the proportion of the population that use methamphetamine has actually decreased from a high of about 3.5% in the early 2000s to the current levels of about 1.3%. This is from our 3-yearly population survey. It's a household survey. And you can even see in terms of, we've got a big wastewater survey analysis that's done frequently, several times a year. Even when we look at the volume of methamphetamine consumed by the wastewater analysis, it's had some ups and downs, but overall it's decreased from 2016, when the data started to be collected, to the last report, which was 2020. But despite the decreasing use, methamphetamine is the drug Australians are most likely to associate with a drug problem, and nearly half the people in the National Drug Survey nominated methamphetamine as the drug of most concern to the community. Not alcohol, not heroin and opioids despite all of the overdoses, but methamphetamine. It's kind of puzzling to me. Methamphetamine's kind of gone down, and in fact it's at its lowest point since we started recording, but the concern has gone up. And it's not just concern that's gone up, we've seen a range of harm indicators that have also increased significantly. So treatment presentations, hospital separations, mostly mental health hospital separations, ambulance call-outs, a whole range of indicators of harms have increased despite the decrease in use. Let me just compare it though to another stimulant that is very popular in Australia at the moment. And you can see here that cocaine prevalence has been on an upward trajectory, that's the dotted line, since 2013, in fact, it has overtaken methamphetamine in the percentage of the population using it by a long shot. But it hasn't had the same harm indicator changes as methamphetamine. So the green line is methamphetamine. You can see these are the proportion of treatment episodes related to methamphetamine have significantly increased. At some point around the middle of around 2013, 14, 15, our services were inundated and overwhelmed with people coming in with methamphetamine problems. But here's an example. You can see the treatment episodes for cocaine, despite the increases in use, have gone up, have stayed completely flat, really. So what's going on? In Australia, like New Zealand, there are different forms of meth available. The powdered form we call speed, and the crystal form, which we call ice. And what has happened, there's been a significant decrease in the percentage of the population that say they prefer the powdered form, and an increase in the percentage of the population who say they prefer the crystal form. Now, they're exactly the same drug, same chemical makeup. If you have enough powdered speed, you will have the same effects as a small amount of crystal, but the crystal is significantly more pure and more potent than the powdered form. So what's happened is that there's a shift towards the stronger form of the drug. So we've got fewer people using, but more problems as a result of this. So I think what my point is, what it clearly demonstrates is that the rate of use of a drug is not interchangeable with the harms associated with a drug. So if we keep focusing on how many people are using and supply reduction and trying to get people off drugs, we're missing the point, really. We need to shift our focus to think about health outcomes and harms associated with using all drugs, but methamphetamine is just a really good example. Now, in Australia, we have a relatively high rate of injecting, but it has actually come down in the last few years. Used to be about 12%, was the highest in the world for methamphetamine. It's now 6%, which is more on par with other countries, similar countries. Most people in fact, use methamphetamine via smoking, and then a range of people use in other ways, so swallowing, snorting, or shafting. If you don't know what shafting is, you'll have to ask me very quietly later, but it's basically what it sounds like. But since they aren't injecting, there's a really low rate of injecting, it means this group is not in much contact with traditional ways that we get information out to people who use drugs. So they're not in contact with clean needle programs, for example. They're not in contact with safe injecting facilities. So it means that we don't have the same kind of access to people who are actively using that don't have problems in order to provide health messages or even direct them into treatment if they feel like they need it. If we just look at the people who are in treatment, we know that people who use, when people who use methamphetamine come into mainstream treatment, they actually do very, very well, despite what you might hear in the media and despite some of the concerns that sometimes practitioners have. So for people who need it, we should encourage them into treatment and be really optimistic about it. One study in Australia looked at outcomes from across a whole range of different treatments, and they found that people who use methamphetamine actually had the highest success rate in treatment out of all drugs. The best option for people who use meth is outpatient counselling. It has the lowest dropout rate by far, and we know that treatment completion is at least as important as the length of treatment, particularly for people who use meth. But really, basically what this study said was that whatever people choose, they do pretty well at. And I think that's important to remember. One of the kind of quirks, I guess, about methamphetamine is that it has a very high relapse rate. So treatment is really effective, but after treatment, it's much harder to stay off. It has a much higher relapse rate than other drugs. These data come from a study that we did looking at outcomes from residential rehab, which admittedly has quite a high dropout from treatment and a high relapse rate anyway. But you can see after 3 months, just under 50% of people had relapsed. That's pretty normal for other drugs as well. We think after 3 months, about 50% normally would relapse. But after 1 year, you can see that nearly 80% had relapsed. And by 3 years, the people who had been through residential rehab looked pretty much the same as people who had not had treatment at all. Just two other studies, one which was the one that showed highest success in treatment, and another study we did which evaluated a 2-session and a 4-session brief intervention, show exactly the same relapse rate. So basically, all treatment works, all evidence-based treatment works, but the relapse is about the same, whatever treatment you come from. So what it says to me is that we really need to focus on post-treatment support to reduce relapse. We know that it usually takes a few goes in treatment to find what works, so reducing harms and improving health outcomes while that process is happening for people who need treatment is really important. And I'll just reference back to the previous session that this is a really critical role for peer support in this post-treatment period. And I think that's one of the really key things that's missing from our own treatment setting, but also probably in New Zealand as well. But if we look at the frequency of use of methamphetamine, about 70% of people use less than 12 times a year, so only a handful of times a year. And about 15% use somewhere between 1 and 3 times a month on average, and there's only about 15% who use regularly, like more than once a week. So the first two groups, they don't need treatment, and part of the third group also don't need treatment. And so we also then don't have access to people in treatment to provide harm reduction messages for the vast majority of people who use methamphetamine. So we need something else. I don't have the answer to that, I'm just raising that question. So the question is, what do we do with the 85 to 90% of people who don't actually need treatment, who will probably never come into treatment? The things that we need to concentrate on, meth has very specific effects on health, part of the impacts on the brain, part of the impacts on the body, really complex brain effects that drive high rates of anxiety, depression and psychosis. So mental health is a big issue. It has an appetite suppressant effect, so nutrition and physical health is a particular issue. It keeps people awake, sometimes for days, depending on their pattern of use. So sleep is an issue, and I'm sure if any of you have ever suffered from lack of sleep, now going through middle age, I am, you really know just how much impact of lack of sleep has on physical and mental health just generally. It also increases libido and reduces inhibition, so safe sex is also an issue for this particular issue for people who use meth. One of the Sentinel surveys of mostly people who use stimulants in Australia, around 70% had casual sex with an unknown partner in the last 6 months, 63 had penetrative sex while they were on drugs, and more than half had unprotected sex with a casual partner. So we really need to think through how we can address some of these particular issues with people who use meth. So what does all this tell us? It tells me that we need to decouple thinking about the number of people who are using and not worry about that so much, and think more about the effects of use and the harms and the health impacts of use. We need to provide effective health and mental health interventions to reduce the harmful use, but we need to really think about how we can access people who use methamphetamine, who are a small percentage of the population, who don't come into needle and syringe programs, who don't come into treatment very much, but there's this big group in the middle that we have no access to, and we need to think about how we can access them. We know that providing health interventions naturally reduces use, so we need to take our focus off that use, how many people are using, and think about the after effects of use. There's some indication, for example, that if people get into mental health treatment, it brings them into alcohol and drug treatment a lot earlier. So it's really important that we think about these particular issues. So I will just leave you with this. Providing health interventions that reduce harm is actually not just a health issue, it's a human rights issue, and that was referenced yesterday as well. The UN Committee on Economic, Social and Cultural Rights has said that health is a fundamental human right that's indispensable for all other human rights. So if you don't have good health, you can't exercise your other human rights. And the covenant of that committee recognises the right of everyone to have the highest possible standard of physical and mental health. And using drugs does not take away that right. So for people who use methamphetamine and other currently illicit drugs, we need to move away from the focus on reducing people using and instead focus on reducing the risks and harms associated with use. And to do this, we need to ensure we provide evidence-based approaches because we know they work, and ensure that the right to good health is maintained regardless of whether people are still using or not. Thanks.
Awesome. Thanks, Professor Nicole Lee, and thank you to you all for joining us with hearing these highlights from the last symposium. I think really important question for us to consider, how do we support those 85 to 90% of people who aren't engaging in treatment services and may not necessarily need treatment services? And if you're wondering, some of those statistics around the proportions of people who use weekly and maybe once or twice a year are relatively similar in New Zealand based on our last data. Although bearing in mind that we haven't done one of the alcohol and drug use surveys in many years, but the last time that was done, it found in New Zealand that out of people who use methamphetamine, almost half of them used once or twice a year. So some important things for us to consider. Feel free to share this video with others that you want to involve in this conversation as well. And join us again next week as we hear the next update from the symposium. Thank you.